This video is a continuation of the previous one, where we discussed each component of the complete blood count in detail. If you haven't watched that video yet, I strongly recommend going back to it first, as it will provide a solid foundation and make today's topic much easier to follow. In this session, we'll focus on how to interpret the CBC in a patient with anemia, and we'll approach it step by step. When interpreting the CBC in a patient with suspected anemia, the first step is to confirm that anemia is truly present by checking whether the hemoglobin or hematocrit values fall below the normal range. In adults, this generally means a hemoglobin level below 13 grams per deciliter in males and below 12 grams per deciliter in females, although these cutoffs may vary slightly across different reference sources. Once anemia is confirmed by looking at the hemoglobin or hematocrit levels, the next step is to identify the cause of anemia. For that, we will check the RBC indices. So after confirming the anemia, we check the RBC indices. We first look at the MCV value and try to classify the anemia using the mean corpuscular volume or MCV. As we discussed in the previous lecture, that MCV tells us the average size of RBCs and also becomes the key index for initial classification and for guiding the subsequent workup. MCV value below 80 femtoliter indicate a microcytic pattern, that is, smaller size of RBCs commonly seen in iron deficiency anemia and in thalassemia. In the previous lecture, we discussed that the hemoglobin is made up of heme and globin, where heme represent the iron. So, if iron is low, the hemoglobin production slow down, and in thalassemia, the iron is normal, but the body cannot produce normal amounts of globin chains, which are also essential parts of hemoglobin. In both situations, hemoglobin formation is reduced. So, think of RBC is like a balloon, and hemoglobin is the air that fill the balloon. So, if there is less air, the balloon doesn't expand fully and stays smaller than normal. So, MCV is low in case of iron deficiency and in thalassemia. If the size of RBC is normal, that is, between 80 to 100 femtoliter, suggests normocytic anemia, which may occur in acute blood loss, hemolytic anemia, or renal failure because of decreased erythropoietin levels. In acute blood loss, when a large amount of blood is lost suddenly, the body doesn't have time to produce new red blood cells. So the cells that remain in the circulation are normal in size but fewer in number. Similarly, in hemolytic anemia, red blood cells are destroyed faster than they can be replaced. But the ones still present are normal sized because the bone marrow continues to produce normal cells, just not enough of them. And also in renal failure, the kidneys cannot produce enough erythropoietin, the hormone that signals the bone marrow to make red blood cells. So the bone marrow produces fewer cells, but their size remains normal. In all these conditions, the issue is not the size of the red blood cells, but the reduced number of them, which is why the anemia appears normocytic. If size of RBC is above 100 femtoliter, it's point towards a macrocytic pattern typically associated with vitamin B12 or folate deficiency, liver disease, or chronic alcoholism. Increased size in vitamin B12 or folate deficiency is because of defect in maturity. When RBCs getting matured in bone marrow, their size goes on reducing. As vitamin B12 and folate are the raw material required for synthesis and maturity of RBC. So in deficiency of raw material, the maturity doesn't happen, and that will lead to a macrocytic anemia. After classifying anemia using the MCV, the next step is to assess the size variation of RBC by looking at the RDW or red cell distribution width. As we discussed in the previous video, the RDW tells us how much the different size of RBCs are present in blood. Suppose we took two samples. In first sample, all the RBCs are nearly the same size with little variation. In this situation, the RDW will be normal or even on the lower side. In second sample, RBCs show wide variation in size, some small, some normal, some large. This greater spread in cell size lead to high RDW. So RDW simply reflect how uniform or diverse the red blood cells are in the given sample. So, if RDW is high and MCV is low, that is, size of RBC is low, that highly suggestive of iron deficiency anemia. Indeed suggests the early stage of iron deficiency. As in early stage of iron deficiency, the most of the circulating RBCs are still normal in size. However, the newly produced RBC becomes smaller due to developing iron deficiency. As the result, you see a wide variation of cell size which lead to increased RDW in early stage of iron deficiency. So high RDW and low MCV suggest iron deficiency anemia. And suppose if RDW is normal but the MCV is low, it indicates the more homogeneous population of smaller cells. Here, MCV tell us the size of RBC is low and RDW tell us the cells are of same sizes. In other words, less variation in cell size. This typically seen in thalassemia or anemia of chronic disease. So in anemia with low MCV and high RDW, think of iron deficiency anemia. And in contrast, if anemia with low MCV but normal RDW suggests thalassemia, where RBCs are uniformly small. That is how we can separate the two conditions in clinical practice. And if RDW is increased but MCV remain normal, that is increased size variation with normal size of RBCs, it often point toward a mixed anemia, where two different processes are happening at the same time. For example, a patient may have early iron deficiency, which tend to produce smaller RBCs, while also have early vitamin B12 or folate deficiency, which tend to produce large red blood cells. Because one condition pushes the cell size down and other condition pushes the cell size up. As the result, the average size of all the red blood cells, that is MCV, can appear normal, even though the average MCV look normal, but the blood sample actually contain a mixture of small, normal and large cells. So this variation in cell size cause the RDW to rise. So whenever you see a normal MCV with increased RDW, this condition is like nutrition deficiency, where iron deficiency and vitamin B12 or folate deficiency is present. And finally, increased RDW with increased MCV points toward macrocytic cause, such as vitamin B12 or folate deficiency, alcohol use disorder, and liver disease. After evaluating red cell indices and reticulocyte response, we turn our attention to the other cell lines, that is, white blood cells and platelets. Their status helps us determine whether the issue is confined to red blood cells or we are dealing with a more widespread bone marrow pathology. If WBC and platelet counts are normal, the problem likely lies within the RBC line, possibly due to peripheral loss or destruction, such as hemolysis or chronic blood loss, or an isolated red blood cell production defect like pure red cell aplasia, or nutritional deficiencies B12 or folate before they affect other lines. However, when anemia is accompanied by thrombocytopenia, it strongly suggests either a primary bone marrow disorder or rapid peripheral destruction. Conditions like thrombotic thrombocytopenic purpura or hemolytic uremic syndrome cause mechanical destruction of RBCs and platelets. In thrombotic thrombocytopenic purpura, which is a rare but serious condition, large thrombus form within the blood vessels. As blood flows through these vessels, red blood cells and platelets rub against these thrombus. This mechanical friction causes damage and rupture of both RBCs and platelets, leading to anemia and thrombocytopenia. Because the red cells are physically injured as they pass through, they break into irregular fragments. For this reason, we examine the peripheral blood smear for schistocytes, which are abnormally shaped red blood cells formed due to mechanical injury. Hypersplenism can also lead to cytopenia, as an enlarged spleen sequesters and destroys both RBCs and platelets. Bone marrow disorders, including aplastic anemia, which may begin with bicytopenia and progress to full pancytopenia, must also be considered. When anemia occurs with low WBCs and platelets, that is pancytopenia, this is a medical emergency requiring urgent evaluation, typically with bone marrow aspiration and biopsy. Aplastic anemia is characterized by hypocellular marrow, meaning the factory is shut down and cannot produce enough of any cell line. Severe B12 or folate deficiency can impair hematopoiesis and resulting in megaloblastic anemia. Acute leukemia must always be considered, where the marrow is infiltrated by malignant blast cells that crowd out normal blood cell production. So if we want to summarize how to proceed with a case of low hemoglobin or anemia, the approach should follow a simple and logical sequence. After confirming that hemoglobin is low, the next step is to classify it using the MCV, which immediately tells us whether we are dealing with a microcytic, normocytic, or macrocytic pattern. After that, we assess the RDW to understand the degree of size variation among the red cells, which helps us distinguish between conditions that share a similar MCV, for example, a high RDW with low MCV suggesting iron deficiency, while a normal RDW with low MCV points more toward thalassemia. If we want to further narrow down the diagnosis between iron deficiency anemia and thalassemia, the reticulocyte count can also be helpful. An increased reticulocyte count points more toward thalassemia, where the bone marrow is usually active and trying to compensate. In contrast, a low reticulocyte count favors iron deficiency anemia. The reticulocyte count reflects how active the bone marrow is in producing new red blood cells, as in iron, B12, or folate deficiency, the raw materials required to produce new cells are lacking. As a result, effective red cell production decreases, leading to a reduced number of reticulocytes in the blood. This is why nutritional deficiencies are typically associated with a low reticulocyte count. Finally, we evaluate the other cell lines, WBCs and platelets, to determine whether the problem is isolated to red cells or part of a broader bone marrow or systemic process. By following this sequence, confirm anemia, check MCV, assess RDW, interpret reticulocyte response, and review WBC and platelet counts, we can systematically narrow down the underlying cause of anemia. So let's interpret this case. In this case, hemoglobin is 9, suggesting anemia. Next step is to check MCV, which is also low, suggesting small size RBCs. As most common cause of low MCV is iron deficiency anemia and thalassemia, so in next step we check RDW, which is high. So this is case of iron deficiency anemia. And if we further check the reticulocyte count is low, which confirm our diagnosis of iron deficiency.